Good day from Texas. I'm Masood Ahmad from Galveston, Texas at the University of Texas Medical Branch. I thank the organizers of World Congress for inviting me to speak. And my topic today is cardiovascular risk assessment in subjects for deployment to Antarctica. A couple of snaps from Galveston. It's a beautiful tropical paradise, just 40 miles south of Houston. So if you're ever in that part of the world, come visit us. This is our hospital, recently completed, very modern facility with all subspecialties, with a nice view. Patients enjoy staying here while they get patient care. Now, UTMB is a world leader in telemedicine consultations and conducts an average of 3,300 live interactive video telemedicine consultations each month. Telemedicine is offered to the inmates of Texas Department of Criminal Justice, that's our prisoners, the underserved communities in rural areas, passengers on cruise ships, and workers on offshore drilling rigs. In 2001, Raytheon, the logistical support contractor for the National Science Foundation in Antarctica, awarded UTMB the subcontract to provide specialty medical services via telemedicine to patients in Antarctica. We service 3 locations: Amundsen, Scott, South Pole, McMurdo, and Palmer, along with the staffers who operate the 2 icebreakers on these research sites. Here is a satellite map of Antarctica along with a geographic overview, and it's on the other side of the world and very beautiful, but it is the coldest, driest, windiest, remotest, and the emptiest part of Earth. And United States has 3 stations, as I mentioned. You can see a little bit of red there in the map, located on this Antarctica. Now, just a brief background. South Pole sits at 9,301 feet. Physiologically, the altitude is 1,000 to 2,000 feet higher because of low barometric pressure. Temperatures at the South Pole frequently exceed 100 degrees Fahrenheit, minus 100 degrees Fahrenheit in wintertime. The extremely cold temperature freezes water vapor out of the air, and humidity at the South Pole can be as low as 4%, which is 2.5 times as dry as the Sahara Desert. The cardiac emergencies that we need to be concerned about, aware of, include unstable angina, acute myocardial infarction, heart failure, and sudden cardiac death. Expert consultation is available to these research sites on South Pole through telemedicine. And the clinics there have thrombolytic therapy available for acute myocardial infarction. The nearest cardiac catheterization laboratory is 8 hours away via air to Christchurch, New Zealand. There is medical evacuation if necessary, and there are documented 34 cases evacuated due to cardiac emergencies. I'd like to present a case that came to us back in 2003. As a 35-year-old male who came to see Dr. Silva, who is an internist, was stationed in South Pole at that time. And the subject was complaining of indigestion. EKG and lab data suggested an acute myocardial infarction. Dr. Silva couldn't be absolutely certain of the diagnosis and the extent of the damage and was thinking about evacuating the patient to New Zealand. Late June, in the dead of Arctic winter, when the sun never shines, outdoor temperatures sometimes plummet to 100 degrees below zero, and patients' evacuation is virtually impossible. So a cardiology consult was requested. And this is where we come in. I'm sitting here in a console for communication with the South Pole, and we were put in touch with our patient and our consulting physician through satellite, communicating UTMB with the personnel at the South Pole station. So the information was beamed from Galveston and South Pole to a satellite hovering 22,300 miles above the planet. And Dr. Silva, who's an internist, assisted me with his first echocardiogram. He had no background in echocardiography, but under my guidance, remote guidance, he was able to manipulate the transducer and the scanner, and an echocardiogram was performed by him with good quality images, and we concluded that the cardiac damage was minor, which was reassuring in that we didn't have to evacuate the patient to New Zealand. I'd like to show you a brief clip of this consultation that details the interaction between us and the physician and the patient via satellite.
Plus the doctor's in Galveston, but his patients at the South Pole. The wonders of telemedicine at 5.
There's still a place for great journalism. 11 News at 5.
Almost a year ago, we told you about amazing technology that allows doctors in Galveston to treat patients at the South Pole.
And now we've discovered information that telemedicine is not just treating, but saving lives there. 11 News reporter Janice Williamson has details on this long-distance link that's proving to be a prescription for better medicine.
All right, we're looking at the left side of the heart here.
It was a first for Dr. Masood Ahmad
Tony's heart attack was in this area.
to diagnose a patient at the bottom of the world.
Excellent.
Initially, I thought it was just indigestion. I didn't realize I had a heart attack.
When Tony Black described his symptoms to Dr. Will Silva, the South Pole physician knew he needed some help.
See, I've never done an echocardiogram before, and really had no idea how to go about it.
Dr. Silva established a satellite link to the University of Texas Medical Branch at Galveston, where Dr. Ahmad was able to see the patient, the ultrasound picture, and talk them through the procedure.
I was really focused on following the instructions. I'm driving, but he's steering.
Maybe we need to rotate the transducer a little bit.
Telemedicine not only gave cardiologists here the ability to diagnose the patient, it gave the doctor on the South Pole peace of mind in the dead of winter. When temperatures are 80 degrees below zero, a medical evacuation is not an option.
Nothing and nobody comes or goes for love or money. About the best that we could do would be to do an airdrop that time of year.
The long-distance link was able to determine the 35-year-old patient suffered a small heart attack that was treatable with medicine.
I feel really good.
Tony Black will survive the wait for the polar spring thaw. Janice Williamson, 11 News.
So the patient did well, was safely evacuated, and came to mainland later on, and he's doing well. To discuss the physiologic effects of the cold shown here, intense cold can cause peripheral vasoconstriction, increase systemic vascular resistance, increase systolic and diastolic blood pressure, and cause coronary vasoconstriction. Also, over time, it can increase plasma viscosity, platelet aggregation, and increase the risk of plaque rupture. We tested the effects of cold in our laboratory by this experiment where we had subjects dip their hand suddenly in a bucket of ice, and then we injected thallium to look at myocardial images while they were having this exposure to intense cold. So 37 to 69 years old, 36 patients who had coronary angiography had thallium injected at 30 seconds of the cold pressor stimulation. And we noticed transient perfusion deficits developed in 24 of 31 patients with coronary disease. And all 5 patients without disease had normal scans. Shown here are the scans. The upper panel is a normal subject with normal distribution of thallium, both during stress as well as during the follow-up scan. And the bottom panel shows a patient with ischemia. The arrows point to the decreased perfusion during stress, which was restored later at baseline. So that confirms that cold has an intense effect on circulation, and in many reports there is discussion of seasonal distribution of acute myocardial infarction. It tends to occur with a higher incidence in cold months in January and December, shown along the edges here. And in this particular report, the incidence was the lowest in the month of July during the summertime. Similarly, there is seasonal variation in heart failure-related morbidity, with the highest numbers of deaths in the winter months December and January shown in the middle, and significantly lower incidence of the mortality in the summer months shown along the edges here. So because of significant cardiovascular changes in cold weather, seasonal increase in acute MI and heart failure, and extreme difficulty in urgently evacuating patients from the South Pole, screening guidelines were put in place. UTMB and Galveston and the Center for Polar Medical Operations serve the National Science Foundation U.S. Antarctic program. All candidates for deployment to Antarctica undergo a physical qualification process. PQ process identifies any physical conditions that would threaten the health and safety of the candidate and that could not be effectively treated by the limited medical care available in Antarctica. Based on the initial risk stratification, if the subjects are non-physical qualified, that's NPQ, they are eligible for waiver, and they are referred for enhanced evaluation. And that's where a UTMB comes in. Now, a lot of this risk assessment for coronary disease is modeled after the aviation industry. Coronary disease is a leading cause of permanent withdrawal from flight status and non-accidental death in military and civil aviation flights. Cardiovascular screening for the U.S. astronauts includes 12-lead ECG, 24-hour ECG monitor, blood pressure monitoring, duplex ultrasound of major vascular structures, and echocardiography and cardiac catheterization when clinically indicated. As well as for retention standards for active astronauts, they get periodic EKGs and symptom-limited exercise stress tests. Now, our report for advanced screening is based on a retrospective analysis of the enhanced screening of NPQ subjects. These are subjects that were not initially qualified during their initial screening due to risk of cardiovascular complications. We received a total of 135 subjects. They were NPQ but eligible for waiver, and they underwent enhanced screening through the period of October 2015 to November 2017. Out of 135 referred subjects, 94.8%, 128, were approved for deployment to Antarctica. But only 100 cases, actually 100 subjects, were actually deployed. This is a busy slide showing clinical characteristics of 135 subjects, but just to summarize, majority of the subjects were male, and a number of them had risk factors including hypertension, hyperlipidemia, smoking, and obesity. We also looked at the Framingham risk score by age, and this is in men and women together, showing age-related curvilinear relationship, higher risk in older age group and lower risk in younger age group. We also looked at Framingham score by sex. The males are shown in blue dots and the females in pink squares. As shown here, there was again age-related increase in risk in males, and the risk in females was much lower when compared to males, even in the older females. Reasons for their enhanced screening, the reasons they were referred to us most commonly had to do with an abnormal EKG or an abnormal stress test. Some of these patients also had arrhythmias. And the additional tests and consults we performed for further assessment included echocardiogram at rest as well as exercise stress echocardiogram. And many of the patients had their electrocardiograms repeated. And for advanced screening for coronary disease, medical records during the deployment period were reviewed for all 100 subjects. And the deployment period ranged from 6 to 324 days, mean of 94 days. The review of cardiac events included acute myocardial infarction, unstable angina pectoris, congestive heart failure, cardiac arrhythmias, and sudden cardiac death. No cardiac events occurred during the deployment in any of the subjects after advanced screening. So we conclude the primary screening process that was done out in the field relies heavily on Framingham heart risk score and cardiovascular stress test. Our protocol is the first description of advanced screening for coronary artery disease in subjects who did not qualify for deployment after initial primary screening. Advanced screening process in selected subjects appears adequate in identifying those with low risk of cardiac events during their deployment to Antarctica. Thank you very much.